Good afternoon, everyone. It is my pleasure to speak on the comparative efficacy of Faricimab for the treatment of diabetic macular edema, a systematic literature review and network meta-analysis. Now, I have been told my entire professional career that I cannot compare across clinical trials. Well, that is not exactly true. There is a highly scientifically rigorous, well-accepted method for comparing across clinical trials. It's used across all of medicine, and I think it's about time we use it in ophthalmology. These are my disclosures. So intravitreal anti-VEGF monotherapy has been the preferred first-line treatment for DME. We use it in a flexible dosing way with T&E or PRN to reduce the treatment burden. But now we have Faricimab, which is the first dual inhibitor of VEGF-A and Ang-2. Can we compare Faricimab randomized clinical trial data to anti-VEGF flexible dosing clinical trial data? And the answer is yes, if we perform a systematic literature review and network meta-analysis. These are validated tools for making comparisons across clinical trials. So the first thing you have to do is a systematic literature review, and in this case, we looked at randomized clinical trials involving bevacizumab, ranibizumab, and aflibercept in flexible dosing regimens. Then we extracted the Faricimab data from Yosemite and Rhine. Then we performed a Bayesian network meta-analysis using a random effects model, and you need a PhD in statistics to do this. We looked at the 4 outcomes you see highlighted in green, and importantly, we included 26 randomized clinical trials in the network meta-analysis. You see that 2 milligrams of aflibercept is kind of the central node. And in this network, we don't talk about statistically significant differences, we talk about significant differences. And in this network, we don't talk about confidence intervals, we talk about credible intervals. So let's take a look at the results. Faricimab T&E was associated with greater change in visual acuity compared to bevacizumab and ranibizumab PRN or ranibizumab T&E, and it was comparable to aflibercept 2 milligrams PRN. What if we look at anatomy? Faricimab T&E was associated with a greater decrease in CST versus all comparators at 12 months, this time including aflibercept 2 milligrams PRN. We also looked at injection frequency, and there was a numerically lower number of injections with Faricimab, and the rate of all-cause discontinuations and other safety outcomes were similar across all groups. So this prompted us to do a second network meta-analysis. Here we're focusing on data from week 12. That allows a head-to-head comparison during the loading phase when every arm of every study is getting dosed Q4 weeks. Here the analysis includes 8 milligrams of aflibercept. Here are the results. Faricimab was associated with a greater decrease in CST versus anti-VEGF monotherapy during the head-to-head initial dosing phase. And in fact, the only time there was a finding that was comparable to Faricimab was when you had dual inhibition of aflibercept plus navascumab. So in summary, in a network meta-analysis, dual VEGF Ang-2 inhibition with Faricimab provided improved anatomical results compared to anti-VEGF monotherapy both at 12 months and at 12 weeks. Thank you very much.
Thank you, and there are seats all over the place if you want to sit down, and also there are microphones in the middle, so thank you very much for this. And the PhD in statistics has to be much more recent than mine, I suspect, for being able to do this. So Nancy, where is this going to help us in making a decision on which drug to use? Now we're very lucky to have a choice in most countries of Europe, but not all.
Well, one of the things that I wanted to emphasize is that this is currently being used in other areas of medicine, oncology being a prime example. It's used for access issues in many, many countries, and that we could possibly be using it for the same reasons in ophthalmology, because it is feasible in a scientifically rigorous way to compare across trials. So I think it will help not only with access, but also treatment decisions.
And taking it to the legal entities and the payers to be able to argue your case. Is that?
Yes, yes. And so I actually hope, I mean, this may be a new concept for many of you, but I'm hoping that we start to see more of it in ophthalmology. I talk to my rheumatology colleagues and they say, oh yeah, it's an NMA. Or I talk to my colleagues in oncology and they say, oh yeah, that's an NMA. So they all understand it, but I think it's relatively new for our field.
Thank you very much.
Thank you.
I still can't see Professor Korbanik, and if he's not here, then we're going to move on to our next presenter.
Yeah, Bruno Cunha, please.